and analgesia, we need to monitor. We need to monitor our patient with pulse oximeter and EKG. Those are the basics. But the real beauty of IV sedation is that we can essentially monitor the facial nerve without a facial nerve monitor. And we can also monitor vestibular function, and we can monitor cochlear function, especially when you're doing ossicular chain reconstruction. And I'll get to that as we proceed in the lecture. So here's a perfect example in the modern world where we have a facial nerve monitor. Um, I'm sure you use it in Cape Town. And there's good indications in otologic surgery to use a facial nerve monitor. When you've got a glomus tumor, because as you remember, uh, there's three cranial nerves that come out with the jugular vein at the skull base, and you want to make sure you don't injure them. Second of all, is that in acoustic neuroma surgery and in congenital atresia, because the facial nerve is in an abnormal position. So those are good indications for using a facial nerve monitor. Do you need a facial nerve monitor doing a tympanoplasty or a tympanomastoidectomy, endolymphatic shunt? The answer is really no. But in the real modern day of age, especially when you've got companies like Carl Storrs and Medtronics, they're trying to promote instruments, machines, and consumables so that they can make money. But the real answer to this, the question is, do you need a facial nerve monitor? Is one's ability to understand the anatomy, and have a good feeling of security, and not a false sense of security, which a facial nerve monitor would afford one. Now, again, the facial nerve has many different courses, and you can look that up in the literature. There's some good articles from the, I believe, the late 60s or 70s, where they show the various, bifurcations and trifurcations of the facial nerve. Um, and if any of you are interested in that, I can easily share it with you afterwards. So a facial nerve monitor gives a lot of people a false sense of security. So this is a simple case. This is a tympanomastoid right ear. Okay, no facial nerve monitor. But again, if you know your anatomy, if you come across a structure, let's say you're doing the mastoid segment of the facial nerve, you can get bifurcation and trifurcations. So if you're working and drilling and you have any doubt about a structure, or are interested in knowing if you've had any injury to a structure, which you shouldn't even have to question, but if you do, you can always ask the patient to, you can always ask the patient to move their face. So here we are, the patient's under IV sedation, and we're talking to the patient. He happens to speak Spanish. So we get him to open his eyes, we get him to open his mouth, smile, move his lips. So I guess you could call this the poor man's facial nerve monitor. Now, I'll have to admit, I was a real skeptic of doing IV sedation on patients and doing surgery on patients until I met this guy from Italy. His name's Giovanni Danese. And he says, Richard, you're crazy. You can do all this surgery. So, I listened to what he had to say. He taught me some techniques. And I probably do 95% of my surgeries now under IV sedation and my otologic procedures. Um, when I told friends of mine back in the States, they thought I was crazy. You can't do a mastoid under IV sedation. I said, you sure can. And I've convinced people that it is a real successful and effective procedure. Now, there's a couple of things you got to realize when you talk about patient selection, and that is obviously healthy patients are great patients. Patients who have high risk for general anesthesia are good patients. And patients who have comorbidities such as cardiac and pulmonary that are not severely compromised are also really acceptable patients. Patients that don't fall into the category of, being qualified candidates for IV sedation are usually people under the age of 18. Now, this is a general rule. There are exceptions. I've done stapes under IV sedations in 14-year-olds, okay? But it was a mature 14-year-old. I felt comfortable. But generally speaking, the younger people are more skeptical and anxious. Revision surgery. When you're doing revision tympanomastoids or tympanoplasties, anytime you're doing a revision surgery, there's scars, and the um, ability for the local anesthesia to infiltrate through the scar tissue is reduced. So there's a higher incidence of patients feeling discomfort and pain in revision surgery. It doesn't mean you can't do revision surgery, but you just need to take that in consideration. And if you're not comfortable doing IV sedation, or your anesthesiologist isn't comfortable, then do it under general. Okay. And again, the most important thing is it's the anxious patients. Okay. Most patients don't even know what they're doing in surgery other than they're getting a problem fixed. So the more you tell them, sometimes it's better and sometimes it's worse. But IV sedation is a real great tool. So what can we do? We can do underlay tympanoplasties. We can do canal wall up, canal wall down, mastoidectomies. We can do blind sac closure. Uh, I do all my stapes surgeries under IV sedation. I don't think I'd feel comfortable doing it under general, for a couple of reasons. As you place your piston, um, you don't want it to be projecting into the vestibule. If it hits the utricle or the sacral, you're going to get a patient to be dizzy, and you can monitor that. If the patient's under general anesthesia when you're doing stapes surgery, you won't know that. Same thing with ossicular chain reconstruction. You can monitor the patient who's undergoing an ossicular chain reconstruction, either on a canal wall up, canal wall down, or in a patient who's got tympanosclerosis and you're doing a transcanal procedure. IV sedation works perfect. Okay, you can monitor the patient's hearing. You can move your torp or port. You can ask the patient, do they hear better or worse? And again, with stapes, you can also monitor the vestibular functions. So endolymphatic sac decompression, another acceptable, and even with cochlear implants in the right environment. Fortunately, most cochlear implants are performed in programs that have adequate financing and adequate equipment, including a facial nerve monitor. So what are some of the setbacks to doing IV sedation? Well, there's pain, dizziness, noise, claustrophobia, anxiety, and backache. And I was curious about this. So here's what I did. This was probably 10 years ago. I took 76 patients that I operated on. And these are the countries: El Salvador, Peru, Ecuador, American Samoa, Mexico, Haiti, and Honduras. And these are the number of patients I operated on in each country, for a total of 76. And I looked at all the parameters I was interested, and I scaled it from 0, which is like, that there was no complaint, to 4, which was, it was the maximum complaint one could have. Now you have to remember, this survey was done upon discharge from the hospital or the recovery area after surgery. Now, most of these countries, other than American Samoa, because American Samoa, even though it's an American territory and they speak English, a lot of them only still spoke Samoan. All the other countries are Spanish speaking countries. I'm bilingual, and I was able to make sure that the question that was asked was understood by the patient. But there's still always that, language barrier. So let's look at this. The first of all is pain. How many patients felt pain? Well, the most important thing was 32 out of the 76 had no pain, 26 had level 1, and then we taper off to 0. So pain was not something I was really concerned about. It was something I felt we could control, and the 0 to 1 didn't, and over half the patients it was not a factor. Dizziness, pretty much the same thing. Noise, we got 8 patients out of 76 who complained about noise. And in review of those patients' surgeries, we found out that most of them I think 6 out of the 8 were canal wall up, canal wall down, or revision mastoidectomies. So there's a longer period of drilling, a longer period of noise exposure. And then the other patients, I think 2 of them in here and 2 of them in this group were patients who had stapes surgery. Claustrophobia, 65 out of 76 felt no claustrophobia. Anxiety in the category 0 to 1. And then back pain, there was like 68 out of 76 had no back pain. So I think it's really important. This little study that I did, it really proves that this is a real tolerable procedure, and the patients have very little complaints about it in the long run. So what are the drugs we use? Okay. Initially, when I started to do this use IV sedation for otologic surgery, I was using Demerol or morphine and Valium. It seems like over the last 20 years, Demerol has become a drug that I can't get in a lot of places. Now we're using fentanyl, and fentanyl is like 1,000 times stronger than Demerol. Fentanyl is a great drug, and in some countries it's so readily available. It's super easy to get. So along with fentanyl now, I'm using midazolam, whereas I used to use Valium. And I'll talk a little about that in just a second. So there's 4 major classes of drugs that we use, okay? And again, you have to remember something. I think, if you're gonna use IV sedation on your patients, the anesthesiologists have a tendency, with all due respects, to think that they know a lot more about giving IV sedation to your patient than you know. But the truth and the reality is the anesthesiologists know one drug. It's called Propofol, and they think it's the wonder drug for everything. I tend to disagree with that. We'll talk about that in a minute. So there's 4 drug classes: the amide anesthetics, opioid narcotics, the benzodiazepines, and the alpha beta adrenergic agonists. So let's look at these. You guys are all familiar with these drugs. Okay, so our amide anesthetics fall into the category of lidocaine, prilocaine, etc. They're all cane drugs. Now, when you go to the dentist, he's going to use these other drugs, okay, like Marcaine, because they have like half-lives of like 4 to 8 hours. We don't need that in otologic surgery. We need about, if you're a decent ear surgeon, you should be able to do a tympanostoid or a tympanoplasty well under 2 to 2.5 hours, okay? And that's the beauty of lidocaine, is that its duration when you mix it with epinephrine is only 2 to 4 hours. And that's perfect for us. So I'm not using any anesthetic amide drug other than lidocaine. And the toxicity, if you give too much, and that it's rare, because most of the time we're only using less than 10 cc's for an ear procedure, would be tinnitus, perioral tingling, numbness of the tongue, agitation, muscle twitching, and lightheadedness. And I honestly don't believe I've even seen any of these complications or toxicities from the anesthetic amide agents. And I've probably done 2,000 surgeries with IV sedation. As far as the opioid analgesics, again, here we have Demerol, morphine, and fentanyl. And you can see here that again, fentanyl is 1,000 times stronger than Demerol. Most of the time, we're going to give the patient 100 to 150 micrograms of fentanyl. Now, I've worked a lot in American Samoa. The average body weight there is probably 300 pounds. So it's twice the body mass of an average American, let's say. And those patients in American Samoa are taking 200 to 300 micrograms of fentanyl. And when we start getting in those high doses, it's almost like enough to take down an elephant. So you got to realize fentanyl is a potent, potent drug. I guess if you snort cocaine with fentanyl, you've got a high risk of dying, because the fentanyl, when it laces the cocaine, really throws, the drug abuser off base because they think they're only snorting cocaine. It's the fentanyl that kills them. So again, fentanyl is probably, what do you guys use in South Africa? Anybody know?
Dr. Wagner, we have fentanyl
You got
as well
fentanyl.
as
Okay.
morphine.
Okay. Well, like I say, I think fentanyl is a really better drug for the opioid class. Okay. And you can see if fentanyl lasts for about an hour to two. Morphine has a longer half life. But again, I've just found that these other analgesics are more difficult to get. Um, the toxicity, we all know that respiratory depression is number one. And that comes hypertension, bradycardia, vomiting, agitation, headaches, urinary retention. And fortunately, if you're going to use any opioid, you got to have naloxone available to reverse it. As far as the benzodiazepines, I really liked Valium, and I kind of still do because Valium has a slower onset. Whereas midazolam, which is probably what you guys use, because in most countries it's readily available like fentanyl, midazolam is super quick acting, okay, but midazolam has a much shorter half-life. Valium is nice because it's a slow onset, it's stable, and then it dissipates out. So my choice of drugs would be, fentanyl and Valium rather than fentanyl midazolam. But again, you got to use what's readily available. And the other thing is toxicity again. Same thing. Benzodiazepines have respiratory depression, bradycardia, hypotension, confusion, and headaches. So the next group is the alpha beta adrenergic agonists, and that's epinephrine. And I like to mix my epinephrine with my lidocaine. I don't like it pre-mixed because I like to use about a 1 to 30,000 concentration. And I'll show you how I do that in just a minute. And so what happens if you have too much of this alpha beta adrenergic toxicity, tachycardia, arrhythmias, palpitations, respiratory difficulty, nausea, and vomitings. Now, I've had probably 3 patients who have had tachycardia up into the high 100s, okay, from just injecting around the ear. And when that happens, you got to just be patient. Okay, you can give them a little carotid massage, but the tachycardia does go away. Now, I'm going to mention ketamine only because there was a time when I went to Tanzania, to the island of Zanzibar, and all they had was ketamine. And we did tympanoplasties on kids using nothing more than ketamine. And ketamine has a similar structure chemically to PCP, which is a recreational drug. Um, and it causes what's called a dissociated or amnesia. Like the patients go into this like twilight zone. They show some slow nystagmus when their eyes are open, and there's a systemic effects like sympathetic stimulation. The beauty of ketamine is there's no respiratory depression, and the airway protection is not affected. The onset of ketamine is pretty rapid. Its duration is usually 10 to 15 minutes. Um, but it gives these weird side effects like hallucinations and unpleasant dreams. If you mix some benzodiazepines with them, and again, now you're going to possibly run into respiratory depression if you overdose them on benzodiazepines, but you can decrease their bad dreams. And the dosage of ketamine is for kids and adults. If you give it IV, is usually 1 milligram per kilogram. If you give it intramuscularly, it's much higher for adults than it is for children. So here's a perfect example. This is a kid who's getting his lip fixed. Now, the most important thing is you watch him. His eyes are totally open. You think the kid's like with you, but the kid is not with us because he's in this disassociated state of amnesia, and he's getting his lips sewn up. He's looking right at you. He's like catatonic. Okay, they'll move their hands and flip their head a little, but those are just states of agitation. But ketamine is a very effective drug for people who don't have the ability to have an to have who can't use other or don't have access to other drugs, or they want a very short acting drug, and they wanted to monitor their patients accordingly. So, propofol, I'm only going to mention this because I really don't like propofol at all. If you remember Michael Jackson, he was a recreational propofol user, and his primary care doctor who used to take care of him gave him a little too much and he stopped breathing. But propofol has a very short duration of action. It's great for induction of general anesthesia, and it's rapid onset. It dilates the peripheral vasculature, which causes more bleeding in the ear. It can help drop blood pressure. It causes apnea after administration and venous irritation. And one of the things if you're gonna use IV sedation for otologic surgery, I mandate with my anesthesiologist, I don't want them to use any propofol. Okay. And I'm going to show you the induction of IV sedation without propofol. But, again, as I said before, most anesthesiologists don't feel comfortable giving IV sedation unless they do it frequently. So here's what I do. Do I pre-op my patients? Rarely do, but if you need to, if they're anxious and you feel you want to give them something, give them like 5 milligrams of Valium 30 minutes beforehand. IM. Okay, or you can give them midazolam. Same thing. Okay, but intraoperatively, we got as I said before, midazolam or Valium, and these are the doses. And then we have our narcotics. We can use meperidine, morphine, or fentanyl. And then we've got our lidocaine, which will mix with epinephrine. So these are the drugs we use intraoperatively and preoperatively. So what do? I take a vial of epinephrine, 1 to 1,000, and then I take lidocaine. I like lidocaine 1%. If you want to use 2%, that's fine. We're not doing a facelift, and we're not injecting large quantities where we could have, an overdose of lidocaine. So what I'll do is I take 10 cc syringe. Whoops, sorry about that. I take a 10 cc syringe. I'll put 9.5 cc's of lidocaine in it, and then I'll put a half a cc of epinephrine. Now that gives me a concentration of about 1 to 30,000 in this syringe. And then I'll put a 27 gauge needle on it. Okay, and that's my solution. Now it is concentrated. And one of the worst things to do is to have a patient who is bleeding in ear surgery, because it's a real limiting factor, in trying to accomplish what your goal is. Fortunately, with IV sedation, the patient's, vascular system is on autonomic, and you don't have vasodilation as you get with general anesthesia. So again, opioids and benzodiazepines are dose dependent. They cause respiratory depression individually and accumulatively. And you've got to make sure if you're going to do this, no matter what environment, that you have naloxone and flumazenil, okay, which is the reversal agent for the benzodiazepines available. So we got to talk about, we know the drugs we're using, we know what we're trying to do. We need to remember that that the nerves innervate the tympanic membrane. We've got the 5th, 7th, 10th, and C2 and C3, which innervate the auditory canal. And then we've got the greater auricular nerve right here. This is the sternocleidomastoid. And then we got the lesser occipital branches of C2 and C3, which innervate the external ear and the postauricular area. Anteriorly, we have the auricular temporal division of the trigeminal nerve, which will innervate the external part of the helix here, as well as the anterior part of the auditory canal. So we've got to block all these nerves so that we can get adequate analgesia. So here's the injection method. I usually inject about, maybe a half a cc, just a blister right at the level of the ear canal. Here's the ear canal here. So postauricularly, I'll inject there, and then I'll go all the way up to the top of the ear, but I do not inject below the external auditory canal. If you start injecting down here, you're gonna get a facial paralysis, okay? And your patient is going to wake up because you're infiltrated down near the styloid mastoid foramen, and your patient's gonna wake up with a facial paralysis, and you're gonna say, "Oh my God, did I cut the facial nerve?" And the probability is you didn't, okay? You didn't cut the nerve, and it's just the dissection of the lidocaine toward the styloid mastoid foramen because you did a deep injection. So I'll do the injection here, and I'm gonna show you this in just a minute. And then I usually inject the concha area from behind, and then I'll inject the canal through a nasal speculum or a Lempert speculum. So here we have a patient. I'm going to inject here. This is my little bleb, half a cc. And then I'll angle the needle and I go all the way up to the top of the external ear. I infiltrate as I pull it out. Then I'll take the needle out and I'm going to stick my finger in the ear canal in just a second. So I'm going underneath the ear posteriorly onto the area of the concha. And I'm forcing my needle almost to my finger. So as I inject, I'm infiltrating the postauricular canal wall, and I'll push the solution that's injected into the soft tissues down the vascular strip. Okay, so I'll do that. And then I'll also come and directly inject here at about 6 o'clock, 3 o'clock, and 12 o'clock. I used to inject with the microscope, but I've found it to be a waste of time and there's no improvement in analgesia. Now I'm going to inject right here anteriorly, and this is the block for the auricular temporal branch of the trigeminal. You need to go, you'll feel that you'll be in the joint space. You have to aspirate, then pull back a little, because if you inject way deep, you got another chance of getting a facial nerve paralysis. Okay. So I inject about a half a cc as I'm pulling the syringe out. And that's it. That is all you got to do. That will handle tympanoplasty. If you're going to take a post-auricular graft or temporalis fascia, if you're not taking a temporalis fascia graft and you're going to take perichondrium, then you just inject the tragus, okay? And just inject the tragus in the posterior canal wall, and that's all you need. The rest of it's going to come from the IV sedation, which you're going to get here in a minute. So again, here's the points again. The greater auricular nerve, we block that by air post-auricular injection, okay? The branches C2, C3, and then we want to stay away from the mastoid tip. We do not want to inject below the external auditory canal. Really important. Now, unless you're doing a procedure where it's required, stay away from here. Tympanoplasty, mastoidectomy, stapes surgery, all the procedures I've listed so far do not require deep injections here. Stapes injection, a little different. You only need to inject about a tenth to almost a quarter of a cc. I usually inject 2 spots. The canal skin is much thinner here than it is more superiorly. And these are the injections, and I'll show you here. So here we have I believe this is, I'm not sure if it's the right or left here, I can't tell, but you need to go right at the junction when you're doing a stapes procedure, right at the junction of the lateral 2/3 and the medial 1/3, and you need to make sure the bevel of the needle is on the bone. And under high pressure, because it's very difficult, you inject very slowly, and you'll see that the skin, the vascular structures within the skin disappear, and we get this white appearance, which is the infiltration of the local with the epinephrine. And that's all it takes for a stapes surgery. One simple injection here, another one a little lower down, and then your IV sedation. So we've shown you the blocks for doing a tympanomastoid. I've shown you the blocks for doing a stapes surgery. And again, EKG, pulse oximeter, and blood pressure. You got to monitor all these things. I've been in situations such as Ethiopia. This was about, 15 years ago. We only had a pulse oximeter. And if you've got a pulse oximeter, under the worst case scenario, you can give IV sedation, because as long as the patient's not desaturating, you're fine. So how do you know if you've got enough sedation? Now, this is the art of, I guess, the whole thing here. And that is, we need to look at the patient, and we're going to infiltrate. He's got an IV. We're going to give him 100 of fentanyl, and we're going to use midazolam. Okay. So we're going to give him 1 milligram of midazolam, which is conservative, because windup is, usually the patients take 1 or 2 milligrams of midazolam to start with. Fentanyl, 100. It's always prudent to give a smaller dosage, and you can always give more. So we'll infiltrate, we shoot it, IV it, okay, and we watch the patient. And we're watching for one thing. We're watching for them to reach the state, okay, of analgesia, so that we can do our procedure. And we're going to look at their blinking reflex. We're going to look at their eyelid movement. We're going to look at their sensation to touch of their eyelashes and their upward gaze. So here's the patient. He just got injected. And you got to be patient. It takes 2 or 3 minutes. We want to prep the patient and drape them and, make the incision and start the surgery. But you can only do that when the patient is ready. And if you're patient enough for the patient to be ready, you're going to have a successful surgery. So you can see they're kind of like straining to look. A lot of movement of the eyebrows, of the eyelashes, and then he kind of closes his eye like, I'm ready to go to sleep, but he'll open it again. And the more you use the IV sedation, the more you're going to get accustomed to observing the patient's actions. And you can talk to them during this phase too, but most of them don't want to talk. Okay. And we get to the point where you can touch their eyelashes and their eyes stay closed. That is the level you want to get to. Okay. And you've got enough sedation on board to begin your procedure. So IV sedation is safe. It is reliable. It reduces mortality and it reduces morbidity. I was in Fiji, 15 years ago, and we were doing a cystic hygroma on a 2-year-old kid who was having some airway compromise. I was doing this with the plastic surgeon, and they had an anesthesiologist whose ventilator didn't work, so he's ventilating by hand. Well, unfortunately, I wasn't paying attention to him because that's not my role per se. But in certain respects, every patient, when they come in the operating room, we're responsible for. Apparently, this anesthesiologist lost a little time on ventilating. The kid took an hour to come out of anesthesia. He went to ICU. He started having seizures in the night, and he died. 2-year-old kid died. They did an autopsy. Obviously, they looked at the neck to see if there was anything going on from the surgery. Fortunately, there wasn't. And it was strictly from anoxic brain damage. They did the autopsy and it showed anoxic brain damage in the histologic sections. About 4 years ago, I was in the Marshall Islands doing a mastectomy on a he was 20 years old. He was Down syndrome. He had been worked up for cardiac anomalies and the whole thing, years ago in Hawaii. And he was a little agitated during surgery. So they put an LMA in him and they gave him Propofol, which was fine. He had his airway controlled. The Propofol was fine because, we were halfway through the surgery. In recovery room, he was extubated. Okay. And in recovery room, after extubation, within a few minutes, he went to fulminant pulmonary edema. He died 12 hours later. Okay. Now, if you look up Propofol literature, there are numerous cases of pulmonary edema associated with the use of Propofol. I don't think many of you have seen those. I hope you never do. But the reality is, you can reduce the morbidity of your patients and the mortality if you use IV sedation for otologic surgery. The other advantages: shorter recovery time, reduced comorbidities, especially in those high risk patients. And I think the most important thing is that I think that IV sedation is God's gift to otologic surgery because, as I said before, you have a patient under general anesthesia, you're not going to be able to monitor their cochlear or vestibular functions. Um, and as far as the facial nerve, it's not as bulletproof as a facial nerve monitor, but there's a lot of advantages. And if you're concerned about whether or not this is a structure such as a facial nerve, you can always ask the patient to move their face. So with that said, that is my experience with IV sedation. I'm a true believer in it. And unless you do it or see somebody do it, it might be hard for you to swallow it as a technique that you might want to do. But, especially in today's day and age where, in many of the African countries, there's really limitations to the availability of anesthesiologists. Um, and I hope that, if you haven't done it yet, you have the opportunity to work with somebody who does, because I think it's something important that you can use not only in your training, but also when you get into, practice in the communities. So if anybody has any questions, I'd be glad to answer them for you. Um, I leave it to you now.
Thank you very much, Dr. Wagner, for a truly fantastic talk. It really is amazing to hear what you can do under local anesthesia. Just to put in context our local situation with our second COVID wave, a lot of our anesthetists were sucked into the ICU, which dramatically reduced our theatre slates, which I think is a global phenomenon, which forced us to attempt to try to do as much of our ear surgery under local here at our own institution. I'd just like to invite Dr. Harris, our local lateral skull base and otology specialist, to make any comments if she's on the chat.
Matt?
Or Dr. Mayer, are you there? Another one of our otology specialists?
Yes, Dr. Wagner, thank you very much for an amazing talk. We read your article and we tried it. Like Matt said, we have no anesthetist. So we did it not for the safety of the patients. We wanted to operate them after COVID and we had no anesthetist. So we opted not to give them the conscious sedation. Have you ever tried to do the tympanoplasty without giving them conscious sedation or a pre-med?
Absolutely. I mean, you can do that. There's no doubt about it. Why didn't you give him some IV sedation? Because you didn't have the anesthesiologist?
Yes, so we tried it. So we didn't have the anesthesiologist, so we had nobody to monitor them. And the idea was we wanted to see if it worked, if we can do it in a setting, maybe not in theater later.
Okay. Well, here's the situation. If you have a monitor, we're doctors, okay? We know how to read a pulse oximeter, okay? We know when the little dial says, oxygen saturation is 90%. And we know when it says that oxygen saturation is 80%, okay? So there should be absolutely no reason we can't monitor blood pressure and oxygen saturation without an anesthesiologist, okay? And as long as we have our reversal agents available, listen, I was in Ethiopia many years ago and I had no anesthesiologist. And you know something? I'm not gonna sit there and let these people with cholesteatomas go home, okay? So you know what? The resident from the States and I did these. We had a pulse oximeter. I set the alarm on the pulse oximeter and we did it. Okay. And when the pulse oximeter said they desaturated, I stuck my finger under their chin. Okay. and they started breathing again. And you know what? You got to play with them for 3 or 4 minutes, and then they oxygenate. Okay. I mean, let's put it this way. To do this in those types of situations, you have to have fairly strong testicles. Okay. You understand what I'm saying? You're working outside the comfort zone. Now, at the University of Cape Town, they probably wouldn't let this happen. Okay. So if you can get like a anesthesia, I guess the registrars in anesthesia are also preoccupied. So, you know, if you have an operating theater without an anesthesiologist, and you have the okay from the anesthesia department to use those drugs and monitor the patient with pulse oximeter, EKG. I mean, I can't read an EKG, but I know what tachycardia is. Okay. Um, if you can monitor these parameters and understand how to work with the patient, you should be able to do these surgeries. If
Just a
you
last
want to send me a
question.
ticket, if you want to send me a ticket to Cape Town, I'll show you how to do this. Okay.
You remember we've got that funny strain that the world is scared of.
Yeah, you have the strain, the South African strain. They won't let me
Yes.
back in the United States.
So we use Xylotox, and the first 2 patients vomited a lot, and we don't know if it possibly entered the middle ear. So have you ever come across it? Because after we did that, we used to either give them dexamethasone before they came to theater to help them with the vomiting, and we would then plug the canal to make sure none of the local anesthetic goes via the perforation into the middle ear. Is it because of the Xylotox that we used, maybe the preservatives
Okay.
in it?
What is Xylotox? I'm not familiar with that.
It's a combination of, they combine the Lidocaine and the adrenaline.
Okay, so yeah, see, I mix my own. Okay, let me tell you something. When I'm doing stapes surgery, okay, if I get bleeding, okay, in the middle ear, like when I'm prior to removing the foot plate, I will shoot adrenaline right in the middle ear. Okay. As long as the vestibule's not open, I'm not worried about it. Okay. If I'm doing a tympanostoid, and sometimes it's weird because you've got these patients and there's no innervation into the mastoid bone. But apparently there are some fibers from branches that we can't see. And I won't inject, I'll just irrigate the field with pure lidocaine and I'll let it sit there for a few minutes. And the patients are fine.
Okay.
The thing is you don't want these drugs getting in the inner ear because that's not appropriate. You don't know, once that vestibule is open, I mean, do they get absorbed through the round window? They probably do, but it's such a slow process that I'm not worried about it. Okay. So, you know what? I would change the drug. I'd mix my own lidocaine and adrenaline and don't use this pre-mixed solution that you're talking about. I try that, make sure your blocks are good. And you know what? If they're not going to allow you to use IV sedation, then you know what? Give your patients some IM medicine. Okay. Give them 5 milligrams of Valium. You can give them IM. I believe you can give fentanyl IM too. Okay. And monitor them. But if the anesthesia department's all scared about, you giving the IV sedation because you're not an anesthesiologist, I can understand that, but you got to find the workaround for it. Start doing just a tympanoplasty. It's pretty, it's basic, okay, and then you work your way up. I mean, I hope that answered your question. I
No,
mean, you're
absolutely.
working, you're working under a unique situation because you don't have, you've got the politics of the hospital and you've got yourself wanting to care for the patient.
So, no, but thank you very much. It's an amazing talk. We will buy you that airplane ticket.
Sounds good. Or I can send you to Italy and you can learn it.
Italy sounds fabulous.
Okay.
Thank you very much, Dr. Wagner. Again, I'd just like to encourage anyone to use the chat function or raise hand function should they have any questions. Now's the time to ask. Just From my side, do you have any experience using Presidex or dexmetomidate? I know it's obviously expensive, not that readily available, especially in an outreach setting, but is it something you use at home in Washington?
Wait, say that again. I didn't hit the first part.
Dexmetomidate, Presidex.
Never used it.
Never used it.
No. The other thing is when I do stapes surgery, I always give them dexamethasone. I give them 12 milligrams IV. Okay. And I usually give them a gram of Ancef, Keflex, and that's it. The dexamethasone is and not only an antiemetic, but it's an anti-inflammatory. And it just, as long as you don't suck, perilymph out of the vestibule, your patient should not be dizzy. The only reason a patient should be dizzy post-stapes surgery would be you suction the vestibule or your piston is too long. Okay.
Oh, no.
So. Oh, look at the dog. What a nice dog. He needs a stapes surgery. Okay. Well, anyway, listen, I appreciate your invitation. And like I say, if anybody has any questions, I'm be glad to, help you guys through it. You need to, you need to get your anesthesiologist to accept what your situation is and see if you can find an adequate workaround, either with IV sedation or give it intramuscularly and deal with it accordingly. It's going to take longer for absorbing. It's going to take a longer onset. You need to be aware of that compared to the intravenous injections. So there's always a way to skin the cat. Okay. You just have to know what they are. Okay. So listen, I'm going to let you guys go to work and I'm going to go to bed.
Yeah, thank you very much again for your time, Dr. Wagner. I stand to be corrected, but I think it's around 4 a.m. your side.
No, it's 10:30 almost.
Okay.
Yeah.
Thank you very much, and that concludes today's meeting.
All right, take care. Thank you much.
You too.
Bye-bye.